Hello, everybody. Hello, Dr. Vinay. Good afternoon, everybody. I would like to give the participants another 2 to 3 minutes to join before we start the meeting.
Good afternoon, Uma.
Hi, Vijay.
ఉమ గారు
Yes, Dr. Rangareddy garu.
మీ వాయిస్ వినపట్లేదు.
That is a difficult one to believe.
I can hear you.
Yeah. Dr. Rangareddy, is it better now?
Yes, it is clear now.
Yeah.
Rangareddy garu, namaskaram.
విజయ్ గారు నమస్తే అండి, ఎలా ఉన్నారు సార్?
Doing well.
సో మీ టూరింగ్ అంతా అయిపోయిందా సార్?
It keeps on. I just returned back, just yesterday.
Okay.
It's a occupational hazard, Andy.
హై రిస్క్.
ఏం చేయాలి?
తప్పదు కదా. అవును, దిస్ ఇస్ ద టైమ్ when you need to take that calculated risk probably.
Dr. Reddy, should I start?
Yeah, I think so.
Yeah. Good afternoon to an August gathering. Luminaries in healthcare research, governance, and colleagues from the region. As we all know that the world we knew and know now has changed, and changed dramatically over the last 24 months. The COVID-19 pandemic has led to some unacceptable loss of life, dignity, globally in countries, both big and small. It's an unprecedented, unparalleled change that we have seen and witnessed, and has brought to the forefront health systems and food systems. Millions have and continue to be challenged about their livelihood. The lessons of the last 24 months are varied, and we notice that while each region had their own ways of dealing and coping with these uncertain times, there have been lessons that have been learned and relearned and unlearned over the time. This is the time for solidarity and keeping in mind the most vulnerable sections of the societies that we deal with on a day in and day out basis. Collectively, only we can overcome the social and economic impact of this pandemic. Are we sure we can? We can't. We can only try. Strengthening health systems is core to this collaboration and to the project that we are about to embark on. To build a resilience and an understanding globally, to share and learn collectively, is the spirit behind this entire exercise. Had it not been for the nature of this pandemic, I guess all of us would have been in a physical environment, sipping a cup of tea, exchanging notes like we briefly did in the beginning virtually. but learning a lot differently than we are today. I take it as a privilege to have all of you on board this afternoon. We will have introductions as we go later, and we'll go straight into the learnings that we want to take forward. On behalf of all of us who are equal partners today in this journey together, I invite Dr. Krishna Reddy Nalamalla, the Country Director, Access Health International. Access Health International is a think tank, health systems, and an advisory organization. He is building in order an institute for health system strengthening. He is a leading cardiologist and a co-founder of Care Hospitals, a large hospital chain with its presence in 6 states. He's the founder of Healthcare Services, a group that's currently evolving into a model healthcare provider system. He was responsible for the development of the India's first cardiac stent named Kalam Raju stent. Founder Relicis Medical Devices to carry forward the legacy of the self-reliance in advanced medical technologies, the true make in India that he actually demonstrated. He's also on the board of trustees for US Pharmacopoeia. It's indeed a privilege to work for him and to work alongside him. And to this August gathering, he actually does not need any introduction, but it's a privilege. Dr. Krishna Reddy would like you to take the process forward.
Yeah, thanks, Uma. I think I should thank everyone who could make it for this introductory session. It is an unusual session, actually. I mean, it was meant to be a physical roundtable with the friends and the like-minded people of Hyderabad who are keenly interested in strengthening the health system here. This was meant to introduce an initiative, almost like a collective initiative. It is not just one organization that is initiating, but we felt there is a collective initiative, and to present that idea behind that collaborative learning. I will take through maybe a brief introduction. A lot of friends have joined here. I think once we finish the introduction, I will call one upon after other to express their suggestions, most importantly, because this is an initiative where collective ideas should give a shape to it. In fact, it should evolve in an organic fashion with inputs from all the stakeholders who matter for health systems. I think that is the objective of today's meeting. I will briefly take through the presentation, and then once that is outlined, then I would request Frank's suggestions as to, I mean, this is just the beginning of an initiative. I keep remembering the proverb, a journey of 1,000 miles begins with the first step. So it is like the first step, just the beginning of a long journey. And a lot of inputs have to come into this journey as it achieves its objective. So with these few introductory words and invitation to all the participants, my colleagues from Access Health, as well as my colleagues from other regional offices in Singapore and China, I will briefly take through the introduction. So I thought I will lay out the context, why the need for this learning collaborative. Then define what are the objectives of this collaborative and how it is organized and how it intends to achieve this objective. I think these are the 3-4 sections which I will try to cover to just introduce the whole idea around the global learning collaborative, specifically for the pandemic prevention, the pandemic preparedness, and broadly into the health system's resilience, because resilience talks in the context of not just the pandemics, but various crises I think the world is facing. So I think all of us aware, and Uma has introduced this thing, I think it is becoming a repetitive thing, but the learning starts, I mean, in clinical medicine, we conduct mortality meeting and the morbidity meetings, what worked well and what did not work well, so that those learnings will make us do better with the next patient with the similar problems. So same way, I think we should not lose the opportunity of learning from the COVID in a systematic way, not in a random way, but in a systematic way. So I think without exception, everybody agrees that health systems across the world, I mean, both the developed world as well as the underdeveloped world, the fault lines have been bared very visibly. I think there was no country without exception. I mean, some countries did very well. Some countries, even the most prepared countries, continues to do bad for a variety of reasons, I think. Then there were a lot of frameworks actually for assessing health systems, assessing countries, which country is prepared for a pandemic, which country is prepared for an epidemic. The various indices were there. But I think in the recent report also we have seen from the Global Health Security Index, where each country is scored based on various parameters around the building blocks of the health systems. But none of these indices were reflective of what actually happened when the pandemic struck these countries. The US was ranked #1 and the UK was ranked #2. But we have seen the fatalities per million population, the infections per million population, they have been highest in these countries. So that means there is a lot more to learn in addition to being prepared for the pandemics. We also witnessed various epidemiological models, very advanced statistical models, were way off the mark in predicting because these models did not meet the requirement, the multiple variables that were impacting the way the pandemic was behaving. So there is a need to revisit some of these epidemiological models as well, as we understand this. Again, I think the concept of whole of systems was clearly evident, that it is not just the health systems that can tackle these pandemics or the crisis, but entire range of social systems, whether it is a labor system or economy or the defense or the foreign relations, the whole of governance and the whole of systems. I think that was clearly evident that health of the people, the health security of the people, it does not just depend upon only the health systems. Similarly, the concept of one health, it is not just the public health, it is the one health of all living beings. That was clearly validated. I think nothing is required to validate this concept of one health, that it is not just the human health that is important, but health of every living being, because we exchange the pathogens with the non-human living beings. So how we handle the non-human living beings is equally important for our own health. I think that concept is one of the important thematic area around which we can learn a lot. And broadening this concept of one health, I think the people started talking of one earth, not just one health, because even the non-living climate has a bearing on health of the people and health security of the people. So the dialogue is expanding beyond public health and to the One Health and to the One Earth concept. This is again another broader. One of the glaring things, I think, the scathing report from the independent commission, which was constituted by the World Health Assembly the last year, which submitted the report this year. One thing that clearly articulated is the leadership and the governance. Right from the global bodies like the WHO or the United Nations to the national governance systems and the leaderships, state level leaderships in the governance, despite the systems being well prepared, how the leadership behaved, how the government systems behaved, that made a difference between a country which was able to respond well versus a country which was unable to respond well despite the wealth and the entire resources at hand. So this is another thematic area. I think there is an increasing focus whether the leadership which manage these complex health systems, the social systems, do they require a different approach, different competencies, different institutional governance systems? So this is another area I think there is a huge focus for learning. Similarly, one thing became clear, I think, when the WHO defined the health systems, they defined the health systems for the normal times. That means they have to meet the needs of the healthcare for the people and health financing needs of the people. But it did not define that they have to be also prepared during the crisis times. I mean, just like the biological systems have enough reserves to meet the requirement during the stress. I keep example of the heart, which normally meets the blood supply at 5 liters per minute. But when it requires, it can pump 30 liters per minute within seconds. That type of responsiveness, the rapid responsiveness when there is a need during the stress, that was, I think, clearly evident when the beds were not there, oxygen was not there, the drugs were not there, the personal protection equipment were not there to meet the rapid surge that was happening. So this is another area in terms of the redundancy in the system, the surplus in the system versus just-in-time efficiency of the system. So how do you balance between these two things? I think that is another reason that was coming out. Some of the innovations that happened in response to COVID, in fact, the fourth phase of any pandemic, that is the learning phase, the recovery and the learning phase, should articulate what actually worked during the pandemic and what did not work during the pandemics. There's so much innovation that was there in the last 2 years. The most remarkable has been the power of human collaboration in bringing out the vaccines, the drugs in the shortest time the world has witnessed in its history. So how these innovations, the way the digital surveillance tools that were used, the way the repurposing of the drugs, the way evidence was dynamically generated, unlike the normal times when you generally see almost a decade before evidence comes into the practice. So there is huge lessons for clinicians, the researchers, the private sector, the academicians, the politicians, and the practitioners. I think this is what I think is clearly evident. And based on this background, we thought this is an opportune time to reflect, research, share, discuss, and debate to learn from the pandemic to prevent future crises and be prepared to respond to them if we could not prevent it. I think this is the context, I mean, why we felt there is a need for a global learning collaborative. The learning collaborative may start at a state level or at a country level or at a regional level, and there is a global level. So there are different level learnings. The global level learnings relate to the international collaboration, international regulation, international agreements, what the World Health Organization recently convened the special session. So there is a learning even at a global level, and there is a learning between the countries in terms of how do they ensure the supply chain continuity across the country, how the information flow across the country. So this learning collaborative is not just the state level. I mean, we beginning at a state level, but ultimately the learnings should be flowing towards a global learning compendium over a period of time. So this is the context behind which this initiative has been started. And so to summarize, the objective of the learning collaborative is to create a global forum where all stakeholders, when I say all stakeholders, it is the leadership, the governments, the private sector, especially the pharma, the biotechnology, the biomedical, the digital technologies. Similarly, the healthcare providers, the health goods producers, the researchers and academic institutions, the think tanks, and the practitioners. So I think when we say the governance, each of these stakeholders are equally important. And government is one component of the governance of the health system. So that's why we thought the forum should be in a position to bring all stakeholders and derive key lessons. I think we should not lose this opportunity to learn the lessons through a process of knowledge co-creation. So it is not just one think tank or one research organization creating the knowledge. The intent is that can researchers come together? Can researchers and the practitioners come together and create a knowledge? Because a research-based knowledge is equally important as a practitioner's experiential knowledge. These two parties learn from each other and co-create a knowledge which translates into a learning material or learning brief. And even the learning process has to be a collaborative, reciprocal learning. It should not be a one-sided learning. So the intent was that the forum should create a process of learning where there is a healthy knowledge co-creation and also a reciprocal learning. And ultimately these learnings, because the forum is trying to bring the leadership of various subsystems of the health systems, whether there is a leadership of the provider systems, the leadership of the product, the health goods and the health technology producers, the leadership of regulators, the leadership of the financial payers who purchase the healthcare, and the public itself. So how this collaborative learning can be there and how this learning can be deployed to prevent future pandemics. I think the aim should be, how do we prevent the pandemics? I mean, just like the discourse in healthcare has shifted from curative care to preventive care, it is not just the preparedness for the pandemics, but how do we prevent the future pandemics? Once we know the threats from biological warfare, for zoonosis, the rapid urbanization with mixing up of the wild animals with the urbanites, variety of things that are there to crystallize what are the threats and what are the mitigation steps to prevent these pandemics. And also to prepare health systems for the rapid response, right from how do we test? For example, if the Omicron is coming, do we have the rapid test? Even at home, a person can detect it. Because the way it is spreading, unless somebody has access to a rapid testing, which is affordable and cost effective, we may not be able to control the type of spread. So there are, I think, a lot of lessons that we can learn from the COVID pandemic itself, how the R&D institutes collaborated with the industries to bring a variety of rapid tests accessible in no time. But can these innovations be institutionalized and become a new norm even during the normal state, so that we are well prepared for the pandemics? Not only the health systems, but I think the pandemic has bared, how do we, the social systems also should be made strong and resilient. So this is the other area that, so the forum intent, the whole objective intent is to create a forum where there is a healthy dialogue between the various stakeholders, there is a collaborative learning, and there is an application of these learnings in actual practice by the leaders in their respective institutions or in their respective systems or in their respective countries or in the respective regions. So that is the whole objective of this collaborative. I will not go into the, but I thought of introducing the resilience in the context of not only just the pandemics, but also the other crises the world is likely to face in the future, be it in the climate change, or be it the mass migration, or be it war and strife. So I think the resilience is the ability to prevent, prepare for, effectively respond to, and learn from crisis. So that is the title, actually, the Global Learning Collaborative for Health Systems Resilience, which encompasses the pandemic preparedness and other crises. So this was introduced as a part of the learning process. I will not go into the more details because that will be touching base as we go. So I briefly, just give a overview of how this is intended to be designed and how it is going to be organized. Then after this introduction, then I will request all the invitees and the members, participants to give suggestions and also seek any clarifications. So one is, this is a voluntary collaborative. It is not driven by anybody. The role of Access Health is only a secretarial support to enable all the volunteers who are part of this collaborative to come onto a platform and support, give the needed support for their interaction. So the purpose I already stated, the knowledge co-creation and reciprocal learning. It is a cross-country network of, so it is not just a state-level collaborative, it is just a kind of an initial informal gathering that we try to bring today. But ultimately, the state-level networks, then the national-level networks, then the regional networks, and the global networks. So it is a cross-country network of technical experts, the practitioners, health policy actors from both public and private sectors. So it is going to be expanded. I mean, what it's starting or what it is now at a state level. In fact, next month, we'll be convening at a national level, at the central level. Similarly, similar exercises of introducing this collaborative and reaching out to the like-minded people across various subsystems of health systems to be part of this collaborative in Southeast Asia region and as well as the East Asia region. In fact, our regional colleagues are also present in this meeting. If time permits, they can also share how they intend to take it in their respective regions and the countries in their respective regions. And because each country has a different experience, has a different culture, different political system, different leadership system, and different levels of economies. So each country can bring out their own learnings, which may be useful for other countries to learn from, or each state can learn from other states within a single country, a large country like India, since each state is equivalent to one country in Southeast Asia. So it becomes important. Each country analyzes its response to the COVID pandemic and greater insights for effective policy action. And this collaborative is set up with a vision to facilitate this synergistic exchange of knowledge. And the participants, whether we call them members or partners or participants or invitees, I'm not sticking to the word of members. It's not a political association. It is just a voluntary collaboration. Are equipped to apply this knowledge towards policy reforms if they are in the policy formulation responsibility, or the other subsystem leadership. It may be a medical association or the hospitals association or the industry bodies like the CII or the Nat Health or FICCI or NASCAM. Their leaderships actually also can take some of these learnings to bring a change within their own systems. That is the intent of these meetings. So there will be, I mean, this is the representation of how a reciprocal knowledge creation will be translated into reciprocal learning, and which will be translated into policies and strategies of leadership at different levels of health systems. Briefly, in terms of the organization, so it is, as I said, it's a voluntary and invitation. Trying to invite people from, for example, the today's invitees are from the government, or from academies like the Indian Institute of Public Health, some of the non-governmental think tanks like Share India, which is into the communicable diseases like HIV and the tuberculosis. Then we have a leadership role at the Administrative College, Staff College of India, University of Hyderabad. We have people from industry bodies, the CII, NASCAM, and also the FICCI and Nat Health. So these are some of the representative organizations and some of the even the political representatives or even the public representatives to be represented in this collaborative. So that is how the participants are drawn from both governmental as well as the non-governmental academic institutions in the health system. To begin with, though it is starting at a state level, but idea is that we will cover the Asian regions to begin with, and with intent to expand to other regions in due course of time. We also invited the donors from, because the Rockefeller Foundation is the seed crystal. I mean, they gave the seed funding to support this idea. But Rockefeller Foundation also, like many other movements in the world, even the donors are coming together in a collaborative way to achieve a shared purpose, so that their resources are well directed in a most impactful areas. So that is one of the element of this organization, is that people will be drawn across the systems, including the donor system, some of the non-health social systems as well. Then the learning process, as I mentioned, we will, one is we suggested certain thematic areas around which the learning process should happen. Similarly, the participants can also come up with some of the sub-thematic areas within the broad thematic areas, because not everybody may be interested in all the areas, but they may be interested in specific areas. So that is where the collaborative will enable creation of focus groups across the countries, across the regions, so that they form a powerful focus group debating and the dialogue around a certain thematic area which is relevant to their domain with vis-a-vis the future pandemic preparedness. So the learning process will commence with the knowledge pooling. The knowledge pooling may be through secondary research, it may be through primary research, it may be through interviews, or it may be through a dialogue of a roundtable discussion among the people. And what will be our job and some of the technical expert partners, the collaborative job is to collate this knowledge material drawn from variety of processes. And then how do we curate it? Curate it in a way that it can be presented as a learning brief or a learning material or a learning presentation. So that then the learning material is taken to the participants so that they can use it at their leisure as an online knowledge portal, or they can participate in rich discussions in a small group, focus groups, whether online or hybrid or physical. And some of those learnings again can be collated and crystallized around certain thematic areas. So this is the overall learning process in terms of the knowledge presentation. So this is what I outlined in terms of the pooling, processing, and the presentation. And the experts drawn from core subsystems of public health or health provision or health financing or health policy or health regulation, health information system, and also other experts drawn from the surveillance, the epidemiology, the digital technologies, the molecular technologies. I did see Deepanvita from IKP, who heads the biotechnology park. So it is important. I think we have representatives from the national R&D institutes like CCMB, CDFT, and IICT. These are equally important. I think the experts, when they interact with the social sciences, the pharma industry. So these are, I think, experts will be drawn to facilitate some of the dialogues and the discussions to enrich this learning process. This summarizes the reciprocal learning process between the academicians and the practitioners. So it is not just a one-way learning, it is a reciprocal learning. Payers and providers, because they did face certain challenges during the COVID pandemic between the health insurers and the healthcare providers. How do we learn from what happened during the COVID pandemic? So can it be there? So then similarly, we have clinicians, their perspective versus health managers, because there is a lot of pressure, especially in the private healthcare providers. How do they balance between the needs of the clinicians and the needs of the businesses? So how do they balance, especially during the crisis situation? There was a lot of unpreparedness in terms of how do they respond in pricing and in balancing between the clinical ethics as well as business ethics. Then we have regulators like IRDA and other regulators and the regulated. We have the producers of health goods and the users of the health goods, then the industry and the policymakers. And we have also the geographic learnings from low-income countries, learning from high-income countries, and the vice versa. So it need not be just one-way traffic. That means only the high-income countries will teach the low-income countries. I think there was a lot of good examples, even low to middle-income countries like the Thailand, some of the Asian countries, even the small countries which fall into low to middle-income countries. They did remarkably well. So why they did remarkably well? So there is a rich learning. I mean, is it their prior exposure to SARS, or is it their universalism versus the individualism of some of the developed world? So I think these are some of the cultural differences, learnings also are there. So this framework summarizes the reciprocal learning of that. And to translate and provide all these learnings, there is going to be a knowledge portal. So whoever volunteers to be part of this on an invitation basis, this collaborative, they will have access to the various learning material and various research material in an organized fashion around the thematic areas. So the knowledge portal is being built onto the website. I think it should be ready in a few days' time for us to launch this portal and start sharing some of the knowledge material which is coming out. The core learning themes, typically the pandemic has the 4 stages of the pandemic in terms of how we prevent it, how do we detect it, how do we respond it, and how do we recover and learn from it. I think these are the 4 pillars of any pandemic cycle. We thought we are entering into the recovery and learning phase until the Omicron struck us. We are still in the rapid response stage. We haven't come into the recovery stage. So the broad thematic areas are outlined here in terms of the pandemic threat assessment and mitigation, and health systems assessment for the pandemic preparedness, because there are a lot of frameworks. How do the countries or how do the states monitor the preparedness of their own health systems? What are the indicators they take actually? The frameworks exist, but are they really being put to use by the governance systems? The rapid response systems. So what are the rapid response systems, including the surveillance systems? There has to be a revisit on this. I think the conventional epidemiological surveillance system, the COVID pandemic has highlighted the role of the molecular technologies, the genomic surveillance, the digital surveillance mechanisms. So all these innovative surveillance systems that were adopted during the COVID in a rapid fashion, can they be adopted when we recover into the normal systems as well, without impinging or making a flip side of these surveillance systems? There was a great learnings in terms of the financial and the social protection, right? Not just the health financial protection, but the overall social protection. And what is the social protection net that were each country, how they fared and what they should do in the future. I mentioned the role of leadership and the governance, especially in terms of the pandemic preparedness and the resilience. One thing is usually ignored in most of the preparedness discourse, the role of the private sector. I think COVID again demonstrated, and most of our health systems have already migrated to mixed health systems. To ignore private sector in any response or in any preparedness will be detrimental to any health system. So how to create that learnings around the role of private sector, how they should be engaged in the planning stage, at the preventive planning stage, at the preparedness stage, or even during the rapid response stage. So these are some of the thematic areas. So our intent of evolution is that it has to evolve organically, because it is not an easy way to bring together so many people across the globe at a country level. There are a lot of procedural challenges when you bring in some of the governmental institutions into this type of collaborative. So it has to be taken in a very slow and iterative fashion, so that we adopt some of the concerns and some of the privacy issues, some of the confidentiality issues in a more mature way, so that everybody feels free to use this forum as a learning forum rather than any other political or any other association type of forum. And for it to be long-term and self-sustainable, I mean, today we are talking of health system resilience, but tomorrow the problem state may be different by the health systems. Can the same forum be addressing those problem statements as well? But to ensure this long-term survival of this collaborative effort, for it to grow organically at a global level, while the seed crystal is laid by the Rockefeller Foundation. So our attempt will be to mobilize a similar collaborative effort from different donors across the world at a national level or at a regional level or at a global level. So ultimately, this collaborative has to evolve in a sustainable, self-sustainable way. As I mentioned, Access Health will be playing the secretariat role.
Dr. Reddy, you're not audible. Shiva, would you speak again? Dr. Reddy, you're not audible. Yeah, please go ahead. Not audible.
I think you'll have to rejoin, sir.
Thanks.
We can hear you.
Yeah, we can be heard.
Yeah.
So while we are just waiting for Dr. Reddy to join back, I'd like to share that straight after Dr. Reddy speaks, we will be inviting all of you to share your experiences and your understanding of how you want to be a part of this collaborative. And Dr. Reddy, of course, like he has already expressed, that we are only going to hold fort as part of the, taking care of the, sir, you're back.
Thanks, Soma. I think, I think there is a problem with the Zoom while shifting the slides. Anyway, I think I completed my presentation in terms of the slides. I was only trying to cover the role of Access Health as a secretariat. As a secretariat, the three regional offices. So we have South Asia regional offices based out of Delhi and Hyderabad. We have Southeast Asia regional office, of which Sejal is the director. She is based out of Singapore. So her team is also present in this meeting. And we have Chang, who represents as the director of the Greater China and East Asia. He was originally originator of the entire area of Southeast Asia and East Asia. So these three regional offices have identified a team of people who will be working around the knowledge creation, the knowledge management, along with the technical experts who are part of the collaborative. So they will be working on these thematic areas in compiling the knowledge work. and also curating it into learning briefs. And some of the knowledge work will be curated into policy briefs. A similar team is around managing the network of partners and the participants in this collaborative. They will be in constant touch with, in fact, some of you who are attending today's meeting, you will be approached individually in terms of formalizing some of the association. Some of the people who could not attend, they did communicate by mail that their intent to be part of this collaborative, not only at this state level, but we reached out to some of the central institutions, both government as well as non-government. So that this team will be moderating and networking all the participants and all the members of this collaborative. The third team, Uma and other team members from other regions as well, are helping in creating the communication channels, the websites, the social media channels, the knowledge portal, the learning management system portal, and some of the materials that will be required. So this is an organization around three core activities, both the knowledge, the learning, the members, and the communication. And also we'll be interacting with the donor community. We are reaching out to them and explaining the purpose of this collaborative. The research work will not only be done by the research team of Access Health, but as a collaborative, we have Public Health Foundation of India. I did meet Professor Srinath Reddy in person, and Dr. Murthy also in person, based out of Hyderabad. So various think tanks. Vijay is there in this meeting. I will be inviting comments and suggestions from the guests who are present here. This is, I think, I would not go into the further details, but this is in brief why the collaborative was felt to be needed, then how it is designed, how it is going to be organized, and how it is going to be evolved over a period of time to a global entity. This is just a beginning, but rapidly our target is to have this entire network across at least the Asian region to begin with, then later expand as per feasibility and the resources that are available to other regions. So I will maybe invite some of the guests to express their suggestions and the comments. Maybe I will start with Dr. Murthy from Indian Institute of Public Health, the Hyderabad chapter. Public Health Foundation of India has been one of the key capacity builder of public health professionals for the last 2 decades. When public health was out of sight of everybody, medical schools and everybody. So I request Dr. Murthy to maybe briefly introduce himself as well as make suggestions and comments. So I will call upon, I think, all the guests and also some of my colleagues where it is required so that the dialogue is carried forward. Dr. Murthy, welcome.
Thank you very much for bringing all of us together. I think it's a great initiative. This is something which is required because there is a lack of a forum like this where you could have, very meaningful discussions happening. I think that is why this is a very timely initiative. I just had a few points which I thought I'll just mention, and this is to do more with the way we can all work together. I think, as you rightly mentioned, the indices that the WHO World Bank talked about, the preparedness index did not work well, as we saw that almost all the countries were lumped at one end of the spectrum. So there are these issues where I think the indices have not been discriminatory enough, and therefore we need to look at how can we develop indices which are discriminatory rather than lump everything together in broad brushes with broad brushes. That doesn't work. And the other thing is that the macro indicators of this nature may not reflect the micro environment where, whether it's a disease transmission or whether it's a health systems response, may not actually be working in alignment with those so-called macro indicators. I think that would need a lot of effort to try and differentiate between them. But my main point was about the fact that you talked about modeling and n number of modelers coming up with n number of estimates and either underestimates or overestimates. I think the biggest problem there was competing rather than collaborating.
Right.
And I think when you look at a grouping like this, that should be our motto. It's not competing, but it is collaborating. If the modelers had come together before spewing out their lava, maybe things would have been different because there would have been a moderation in the way these figures would have been presented. So I think that sort of a thing is important. We have to keep our egos aside because competition, to look at a pandemic preparedness, competition does not help. It will be the bane of important collaborations. Two other issues, equity. And I think, again, we need to look at how do we transcend those national borders or nationalistic borders. An initiative like COVAX failing miserably because of these nationalistic tendencies. So we need to look at transparency and equity, I think, as very important components of this collaboration. Autonomy of authority and decentralized functioning as to how we can actually do that. And you mentioned One Health, One Earth. I think at the end of the day, the community is at the core of both One Health and One Earth. And without their active involvement, it can't be a provider-driven narrative. And I think as we progress, we need to look at how do we get the community in to be a meaningful partner in carrying this work forward. My last point would be that you have, as I see, 31 participants today and maybe another 10, 12 who couldn't join today. So we're looking at about 50 people. In every meeting with 50 people participating over a short period of time, I don't think we'll make much headway. So we need to look at having maybe two groupings within this, one more like an executive, which looks at points which can be shared with the wider audience, take their feedback, work on it, and come back. So it will be a to and froing between a smaller group and a bigger group. Otherwise, I think we'll have a difficulty in progressing, Dr. Reddy. Thank you for the opportunity. I think this is a laudable effort and wonderful that you are steering this forward. Thank you.
Thanks, Dr. Murthy. I think this is the type of discussion I was meaning for the collaboration, actually. The pulse of wisdom and ideas that come. Yeah, the last point, in fact, that is the idea. Once there is a broader umbrella of a overarching theme, to break it down into focus groups, the smaller groups, drawn from states to meet at a central level, and drawn from country to meet at a regional level, and drawn from the regions to meet at a global level. So this is the actual hierarchical approach in terms of, it's almost like the rivulets joining to form a big river. But at the same time, to keep the discussions meaningful, fully echo your suggestion that ultimately these will be regrouped, not only within this state group, but for example, two people from each state is interested in discussing certain aspect of it. Then we should be able to convene, say, 20 people across 10 states or 15 states or 20 people across 5 countries or 10 countries. So this is the approach. So I fully aligned with what you suggested. Thanks again, Murthy. I think I will invite from one think tank. I think I will invite from the private sector, Deepanvita. She heads IKP, the entire biotechnology park. Please do introduce yourself. We haven't met, but we know each other.
Thank you. I'll just increase the volume a little, maybe. Thank you, Dr. Reddy. Yes, we haven't met, but we know each other for quite some time through Manjula and through various other networks. And I've met Uma as well. So very nice to be here. I think this is a very important agenda that you have put together, because most of the groups that are working are either siloed in terms of doing research or siloed in terms of policy. And I'm talking, and Vinay is here representing CCMB, and there'll be other institutes. So how do we actually put together cross-functional, cross-border forums where discussion can happen in a more meaningful way? Because if we have to talk of One Health, we really need to start with the premise that there has to be collaboration, much more collaborative effort. So Dr. Murthy mentioned a lot of important things. I felt one point that could be strengthened is advocacy and citizens' responsibility and citizens' voice. Dr. Murthy mentioned community. And the other thing I was feeling is, if I look at the audience here today, I'm not sure whether we have included institutes working on animal health. That will also be important because veterinary science and animal health is extremely important. Agriculture, I would think that would also be important, because if we have to cover AMR, we have to get into how antibiotics are being used for cattle, for animal and plants, the expired antibiotics being used for plants. And so I think it's a very broad issue, and we may need to, of course, I know we can't have everybody at one forum, but maybe some forums will be required to look at a little bit of more focus on animal health. And DBT has recently formed a consortium of 27 institutes in India, and they're looking at surveillance and diagnostics and early signals of pandemics or any kind of change that's happening. So maybe I can link this forum and the Secretariat to the DBT consortium. So NIAB is part of it, which is in Hyderabad. And there are, I think, 7 medical colleges, including AIIMS Delhi and others. And there are institutes from and laboratories from the Northeast area, which will be important for us because there the disease prevalence and the movement of pathogens has to be really looked at. And that is one thing I'll be happy to link the group. Regarding the position of WHO and UN on some of these issues, I did not really understand how do we actually link them, because you mentioned we'll look at Asia to begin with, but these are global problems. And what would that relationship be? How do we make a linkage with that? I thought it would be good to have some clarity in that aspect. I'll stop here. And maybe if there are other suggestions that I have, I'll be happy to give. Thank you, Dr. Reddy.
Yeah, thanks, Deepanvita. I think you made some of the valid points. In fact, the point on One Health and involving the veterinary and agri sectors as well is part of the thematic area of how do we assess the threat perception?
Yeah.
How do we mitigate it?
Yes.
So under the thematic area, in fact, all these elements and the groupings actually will be brought in as a focus group. So that's second, in terms of bringing in the DBT, DST, DRDO, ICMR, and CSR. In fact, fortunately, most of them have Hyderabad connection. Okay, so that's why I said Hyderabad is the mini India. All the four DGs, today's DGs are from Hyderabad, or they worked in Hyderabad. So it's a good connection that we can have. In terms of the bringing in the multilateral bodies, I mean, I think once the collaborative forms and there is a dialogue around the thematic areas, and the governmental institutions are also actively participating from different countries, and naturally the multilateral bodies will be invited to some of these fora. I mean, for example, the CRO is there in Delhi, the WHO Southeast Asia Regional Office. So those regional offices, in fact, our Access Health regional offices do work closely with some of these regional offices. The WHO, the World Bank, ADB, UNICEF, ILO. So there is a good network. I think we will be roping in, and definitely we will take your network across the country in bringing in the right players into this collaborative. And thanks, Deepan.
Thank you.
Maybe I next invite Vijay, Vijay, close friend for the last 20 years, a passionate infectious disease specialist, University of Chicago. So Share India is the main architect running a large infectious disease program of HIV and tuberculosis. Very passionate about infection prevention and control. So Vijay, over to you. Brief comments on this initiative.
Thank you very much, Dr. Reddy. I think a great honor and privilege to be working with you and to be associated with you. So yes, I'm part of Share India, but I'm also part of the Public Health Foundation of India. So a little bit of incest out here. And although, my obsession has been with infectious diseases because that was the original discipline that I went into, I would like to make it very clear that I think that the distinction between communicable diseases and non-communicable diseases is a false dichotomy. And I think that we should focus on health. And the core competency that Share India actually brings is implementation science. Yeah, so that's what we've really been focusing on for the last 20 odd years, is taking national policy and trying to implement it at the grassroots level and show a change. And at the same time, learning from that change. And one of the things that we have learned, I think, is that one needs to have a participatory approach, and one cannot do it on our own. I mean, the prescriptive methodology simply does not work in health. That's the first thing that we learned. The second part that we have learned that I think the COVID pandemic illustrates eminently is understanding complexity, that humans in human health, human societies, our entire world is a complex adaptive system. And we ignore that at our own peril. So I would echo what the previous speaker said, that we need to bring in much more expertise from the veterinary sciences, a great deal more expertise from the environmental sciences. And we need to integrate all of that into our understanding of One Health and One Earth. And at the same time, I think the other area, particularly in terms of resilience that we need to learn from, is try to use our existing expertise to a priori look at the relative costs and benefits of various policies, which I think that we've been a little bit remiss at that, particularly when it comes to lockdowns, because we know a lot about the impact of lockdowns, and we could have predicted a priori, in my opinion, that the lockdowns would do nothing more than flatten the epidemic. And it is still debatable whether we actually save more lives than not with the lockdown, because the lockdown did cost lives and livelihoods. So I think this kind of very careful scientific methodical evaluation of evidence, looking at various kinds of policies, should be integral to our endeavor. And we need to be a credible voice that is trusted by people, because as you have seen, what the COVID pandemic also put up is many, many areas where people unfortunately fell victim to a lot of misinformation. Ivermectin is a great example. So I think that those are the areas, but fundamentally, I do think that what we need to assiduously work on is rebuilding trust and confidence that we are willing and humble enough to put in the effort required in a participatory manner to build a system that is good for everybody, because at the end of the day, I think what we are all focused on is that we have a purposeful life with autonomy and dignity for all. So once again, thank you very much for this opportunity and the great honor that you have done for me.
Thanks, Vijay. I think we'll be meeting more often through these meetings. I do see Deepali from Rockefeller Foundation join. She has a hectic schedule. I think thanks her for accommodating this unusual time for her. Deepali represents Rockefeller Foundation as Managing Director. She is overall responsible for the Asia region. And Abhinav also is there in this meeting. I would request Deepali to introduce, and also amazing work which Rockefeller Foundation is doing across the globe with reference to the pandemic. Not only pandemic, I think the climate is other focus area. Deepali, please, over to you.
Yeah, thank you so much, Dr. Reddy, for inviting me to this session. And I know I wasn't able to join the entire conversation, but at least what I heard, I mean, it's just such an important conversation that is happening, and with all the right actors. I want to thank everybody who's been able to take the time. And I think this is just part of the journey that Dr. Reddy and team are kind of embarking on. And I'm hopeful that, we'll have many more conversations in the coming weeks and months, because I think, we really need to be putting thinking hats together to really see how this collaborative is really going to work for all of us. That, we have a range of stakeholders together to really create a responsible and resilient ecosystem. This cannot be a one-off effort or an isolated effort. Collaboration, of course, is going to be critical and crucial to get ahead of the pandemic. And also, how do we really build trust in this process is going to be critical, because that's something that we've seen was lacking, at least in the early days. Things are getting better, but I still think we have a long way to go. Preventing the next pandemic is a shared responsibility, and conversations such as these will help us accelerate the action required. This learning collaborative will certainly help make further improvements in the science and technology facets, like sequencing technology, training to overcome barriers to fill in large gaps in genomic data across the globe. So, one's aspirations are really big, and I'm pretty sure with Dr. Reddy's vision and all the efforts that he's putting behind it, it's really going to be a collaborative that is really going to serve not just India's interests, but truly be global. It aims to also emerge as a platform for communication, knowledge sharing, and peer-to-peer learning between the various collaborators working on strengthening health systems. So I really see this as an opportunity to harness the collective wisdom of a collaborative and to also identify gaps in resourcing and capabilities for strategic engagement with governments and private sector players to really eliminate at best and minimize as a start. So the unprecedented challenge to our public health system, as we've witnessed in the last 2 years, really goes beyond borders and requires information, capital, and know-how to be shared and activities to be coordinated to really bring about effective lasting change. With this sharing of knowledge and information, we will know of the successes and failures of within the different country contexts to help deliver solutions that can really address those gaps. We need to have scalable, hyper-local, community-led programs to improve vaccine access and accurate information to have a strong pandemic prevention response from the larger health system. Collaborating with networks of thousands of scientists, doctors, and community health workers around the world is how the foundation was really able to invent the discipline of public health as we see it today. So I really urge all of us to really move beyond the silos and really meet the moment with accelerated knowledge sharing. In our collective quest for large-scale impact, I'm constantly reminded that the whole is greater than the sum of its parts. It's very evident that the challenges that we face today can only be solved by collaborative efforts. And we've all been talking about that. Recognizing the importance of health system resilience to current and future health shocks, the Rockefeller Foundation is investing, as Dr. Reddy said, in increased genomic and epidemiological surveillance capacity and supporting an ecosystem-based approach to knowledge sharing across borders. It is to aid this effort, we are keen to see this collaboration come to fruition with Access Health International, as this will really bring a robust research, learning, and implementation approach to building this network. All of us at the Rockefeller Foundation are very excited about this collaborative, and I hope that the rich learnings from the work here will become a cornerstone for how health systems are conceptualized worldwide. So quite a bit of a responsibility on this group and Dr. Reddy, but I'm sure that's going to happen. From the discussions and deliberations today, it is evident that this will be an active group of members. I encourage you to not only be active in your participation post this event, but we also need your leadership in really directing the collaborative towards success. Thank you so much.
Thanks, Dipali. I think it was a wonderful exposition of the spirit of collaboration. I think because the world will not be safe without that collaboration. In fact, the human beings dominate this world because they collaborate. When they fight with each other, they destroy. So thanks again, and I personally thank for that initial seed crystal that you laid there. And I'm sure, I think we promise on behalf of our group that we will do justice to the trust that was reposed through that seed crystal. And we know that that crystal will be grown to sustain in a long-term fashion. Thanks again for coming at a late hour. I'm sure you might be from Canada or US. I think it may be ungodly hour for you to be part of this. If you are present throughout the meeting, you're most welcome. I think rich discussions will be there. So I call upon Professor Rangareddy. I think he's again a passionate person about infection prevention and control. And his passion has been to train people across the country in various hospitals on infection prevention control. So it's a passionate, it is area which is close to him. So he not only represents just the Hyderabad, but he is a articulate advocate across the country with a vast network. Rangareddy, over to you.
Thank you very much, Dr. Reddy. It's really a pleasure and honor to be part of this August gathering. It's, I think, very timely initiative. When we started, you remember in 2016, the Infection Control Academy with one single agenda to create the capacity of infection preventionists. I think most people silently laughed at us, but I think it has proven to be a good idea and a good initiative, which, if not actually, it could lessen the burden, but at least it has probably created some awareness, which probably would have saved some lives, and probably some of those critical elements which are required to tackle the pandemic. Probably it would have helped to bridge that knowledge gap. Since the time is very less because so many participants had to speak, I would like to, kind of highlight two, three things here. One thing, probably more of tangible things, and second is intangible things, and probably third one could be how this group can go ahead in terms of organizing together, collaborating together, and getting some outcomes out of it, right? The intangible things, at a global level, I'm not talking about today's meeting, but the intangible things, two of the major deficiencies or the casualties of the current pandemic, what I see is the evidence-based medicine. I think we have completely, gone out of the board in terms of actually bringing the evidence to kind of preparing the protocols or, getting any kind of medicines or the vaccines or, anything actually. I think, the evidence had to be brought back to the medicine. Otherwise, it is going to be very difficult, and it is the whole, system is going to collapse, I think, very soon. Yes, in a pandemic situation, it is inevitable that some of the conventional norms probably can be overlooked at. Something like, when the vaccines are fast tracked, giving the licenses, etc., etc. But that has become a precedence. If you look at even other medications, which are given the approvals, the clinical trials which are happening, even without having any permissions, all those things probably it is going to be a monstrous thing over a period of time, looks like. And all that we have built in last few decades in terms of evidence-based medicine. I remember as a student in mid 90s, evidence-based medicine used to be the most fad word, but I think we are slowly going away from that. That is one tangible thing. The second tangible thing is the equity, right? The health equity. We have looked at what is happening currently in Africa. Less than 7% of the people getting immunized with vaccines. I think that is not humane. That is not something which we can call as collaboration. You in the initial opening words, you said that a large human collaboration and all that stuff. But those words look very fancy in the light of what is happening in Africa, what is happening in the low and medium resource countries where the resources are constrained. That means you don't have money. That means you cannot have right to the health. That is what we are telling on the face to these people, millions of them, who are just waiting for a few consignments of vaccine. That is kind of intangible things. When it comes to tangible things, yes, it is understandable that if we really want to be prepared, there is no other option other than re-looking and revisiting our health systems and making them resilient so that we can very rapidly detect, kind of assess, report and response to all the novel threats, which are both emerging and re-emerging infections. I think, we would not say less even if we talk for hours about those emerging and re-emerging threats. That's on probably on the tangible side of it. And as far as the organizational matters are concerned, I work with UKIBC, that is UK India Business Council, where we are working as a group to deliver university social responsibility on various topics. How we have organized that is to have the subgroups. I think that becomes more manageable. Probably this group could be split on probably thematic areas, and probably there could be subgroups which they can independently work and bring those areas for the common general meeting kind of discussion. Other groups can actually add on and probably bring their expertise and also the knowledge to further build on that. Probably I would stop here so that more people can get opportunity to kind of share their knowledge and wisdom. Thank you.
Yeah, thanks, Rangareddy. I think, yeah, this meeting was, as I said, just a beginning of the journey, long journey, and all these suggestions. Actually, that was the purpose of this meeting, was to elicit suggestions as we go along, how to make it more robust and more organized in a fashion that it becomes productive. Thanks again for those comments. I will invite Subodh, because as I mentioned, the leadership and governance, I think one of the key elements, and the Administrative Staff College of India, I mean, which has been nurturing the administrators of every state and every center in this country. They are the best positioned to understand in what way this area has to be looked at and how do we strengthen the capacity of this area. Subodh, I think just please make some suggestions and on behalf of Administrative Staff College of India.
Thank you, Dr. Reddy. I think ASCII and Access Health has already been working, and I fully endorse with all other participants on the importance of collaborations. I think I would not agree more, because I think we all work in silos. I think the last 1 year, I think ever since we have collaborated for multiple activities, whether it's health system strengthening or for these our own programs, I think we have seen those benefits, and especially we have also realized how difficult it is to get that connections with the government, and but all small steps are going to help us in big ways. So I'm sure that this collaboration is also going to reap rich dividends in the future. Just 2 points. I think most of the points were very well covered, I think, by especially on the subgroups and how we, because larger group will always be difficult. But I think very important things about the balancing of the primary research and the dissemination. So we may do a lot of things, but I fully agree that at the end of the day, a good dissemination with not very extensive report, but policy briefs and manuals should reach the right things, and not very sort of regular updates on the dissemination will go a long way in sort of helping the policymakers. So I think that's something we should really, so a nice balance between primary research, creating evidence, and good dissemination. So I wish all the best. I will be very excited as part of ASCII to be part of this. I think obviously our strength will be more of capacity building, and whatever way will be there to support. Thank you, Dr. Reddy.
Yeah, thanks, Subodh. I think yeah, the point is well taken in terms of how do we curate the knowledge into a language which a non-technical person can understand.
Correct.
Because when the researcher talks in the research language, a politician or a bureaucrat may not be able to understand. But how do we translate the same depth of knowledge? I mean, just like we say informed consent, how we explain to a patient in a language which the patient and family can understand. The same way, if a politician has to take an informed policy decision, how we curate. I mean, I think that is where we have to join hands in bringing our own expertise, because we need good communicators of the same deep knowledge, how they communicate in a simple fashion. And thanks, Subodh. I think we have been wonderful collaboration in the last 1 year, and we hope to strengthen that, especially in the area of leadership development. So that was pending from our side. I saw Harish joined. He took permission because he had some other meeting which could not be avoided. Harish Iyer, he is from Gates Foundation, based out of Hyderabad. He is the man behind the entire vaccine support. So Harish, please invite your comments and suggestions for this collaborative.
Thank you so much, Dr. Reddy, for inviting me to speak here a little bit. I am sorry I missed the first bit of it, so I really apologize for that, and I hope some of what I'm saying is not repetitive. I think, we are seeing again the Omicron variant come through India. I am praying, of course, that India is not significantly impacted, given that we have been exposed significantly. But one of the things that it keeps coming back now is, how will we deal with this, right? What is the data available? Do we need, big question around the countries, when do we need boosters? Do we need boosters that are specific to the variant of interest, or is it one of the other vaccines? the broader world, the high income world certainly is able to generate lots of data and say, well, what happens if you get infected once? Will you get infected again? How safe are you? So a lot of these kinds of data questions, which are research questions, and hopefully helpful for clinicians and healthcare workers to treat any potential patients, are something that is, I think, very, very, very important for us. I think that is something that would be great to understand. How do we bring together data? And Dr. Reddy, we work together quite a bit on the health system and digital and everything. Can we use any of those digital tools to analyze and understand who is at risk, who is not at risk, in a relatively anonymized way? Obviously, this has got to be completely anonymized and de-identified kind of way. But I think it's going to be very, very critical, because health system is likely to get overwhelmed if something bad happens. We thought next wave will come maybe many years from now, but my God, we are seeing an experiment right now happening in life. So I think that, and I think accompanying that is the research question about how do we do research? What are the regulations around research? Very much to Professor Rangareddy's point, who just spoke before me, and I heard him say about evidence-based medicine. Absolutely. How would we do this in a way that we do not lose the public's trust? I think the public's trust is very precious. You already see certainly in the richer parts of the world, a mix of populations where there is hesitancy, lack of confidence, people saying, does this work, does it not work? We've heard about hydroxychloroquine on the small molecule pharma side, hydroxychloroquine antibodies. They work against some strains, they won't work against other strains. So I think there's a lot from a research and post-introduction evidence perspective, where it would be good to collect data to help people in healthcare, to help governments think through what would be the how are we getting geared up to address this issue very, very carefully. We are also doing some efforts ourselves at the Gate Foundation in terms of understanding how boosters are working. I think companies are doing it on their own, and hope whatever we do, we will try and make sure we publish it. But should it be the whole discussion around heterologous boosters? Who should get boosters? Is it older subjects? Is it only antibodies? Is it cellular immunity? All these kind of deep questions. And India luckily has had a significant, R&D base, in that sense of product development base. So we've been lucky. I think the point that the earlier speaker made about, how the inequity is very high will also be something absolutely the globe has to take into account. How do we make sure our brothers and sisters in Africa are not left behind? Luckily, in quotes, it appears that the previous waves have relatively left Africa, mildly scarred. It does not it still leaves open the question about where these Omicron variant with huge number of mutations came from. So there is you can't save yourself in that sense. The rich world certainly cannot save itself by itself alone. It has to think through this. This is the word global in this whole collaborative, right? Why is the word global there? I think very much part of how do we make sure that the world together works on this topic. So maybe I'll stop there, but I think that is an area of certainly of deep interest and some understanding that I have. I don't have a great understanding about much of the delivery, which is all very much more complex. Are we arriving in the supply chain, and how do we get down the human resources for health, the financing? Dr. Reddy, you know a lot about this, and there may be many others on this call who know a lot about this, but I just thought I'll leave my comments to areas that I'm somewhat familiar with. Thank you so much.
Thanks, Harish. I think you brought one of the most important area of, in fact, there are examples of how some of the countries could innovate in what I think today newspaper came from an Australian perspective, that how do you dynamically generate evidence? Unlike the olden times, evidence generation to guidelines used to take 15 years. But how do we actually transform it into a dynamic evidence generation, translating into guideline in a short period of time? It is not for 15 years, it should be 3 months, 4 months. And that exactly happened. I think we have seen the clinical research network that was there in NHS, which showed us the benefit of steroids. Okay, so it is not difficult. I think I did meet, we are meeting ABDM, ICMR, and NCDC. In fact, for this very purpose, how does the country actually put in these three resources? You have extensive ICMR network, you have NCDC surveillance network, now you have the digital technology standard-based network. How do we convert these three into creating a base to test the new drugs, the repurposed drugs, the new vaccines, to answer the question on the boosters, the reinfections, the breakthrough infections? I think this is the most, I think this is the type of dialogue I think this collaborative should encourage, that this becomes itself a kind of a thematic area for focus groups to be brought together, both from the government as well as from the non-government, so that we come up with a permanent solution so that tomorrow we are not searching where is the evidence in India. Why take only evidence from, because our innate immunity may be different, our culture may be different, so we don't know how we will behave unless we have the data. I fully endorse that. I think that's another good idea for subgroups to take up the thematic area. Thanks, Harish, and we continue to enjoy our dialogue.
Thank you, Dr. Reddy. I just want to point out another thing that is connected to this, which is broader, which is that excess use of antibiotics. We also don't know whether secondary infections were a problem or not. I know we discussed this over chai one of those days, but excess use of antibiotics also has other spillover effects into the resilience of health system. So
we have seen the mucormycosis story.
Yeah.
Total indiscriminate use of antibiotics and steroids. Okay, so no evidence-based, no guidelines. Even guidelines are there, practitioners are not really aligned with that. Thanks, Harish. I think both important topics to be included in future discussions. I take this opportunity maybe also to invite my colleague from East Asia region, Chang, who is there in this meeting, because he had already done work with Rockefeller Foundation in crystallizing how the digital technologies were used in China very effectively, very innovatively in tackling the pandemic. I think this is one more area of disruptive digital technologies, how they can become new norm into the future. Chang, can you say a few words and introduce how you propose to bring this collaborative to fruition in Southeast Asia and East Asia as well? Chang, over to you. Is Chang there, Uma? Or I saw him earlier.
Sir, I think Tina is there.
Tina, yeah, you can chip in, Tina, if Chang is not there. No, I think they must have dropped out. I would like to, I think, invite Dr. Ambuj, with whom I had an interesting discussion during the recent panel discussion organized by IKP. So we wanted to discuss again. This forum provides some more dialogue. Ambuj, please give suggestions in how to organize and take collaborative forward.
Thank you, Dr. Krishna. And yes, I do go back to the IKMC conference, where you actually talked about health systems, the entire perspective about how to look at healthcare from a health systems perspective. And I think that is being reflected in the call here as well. So for the benefit of the audience, I'm Dr. Ambuj Chaturvedi, Senior Vice President with IKP. I recommend to ma'am, Deepak Bala ma'am. And while ma'am has talked about entire strategic overview from IKP standpoint on what she sees on where this collaborative effort go through, I'll talk a little bit about the implementation piece or the tactical piece that's coming in. So I have three different hats. One as heading the health initiatives at IKP, and which is where we looked at a lot of work during the pandemic in terms of setting up funds to support entrepreneurs, to look at how we can solve the entire different sets of we faced with the pandemic, the ICO fund. We did work, so during the third wave, which was a predictive kind of work that we actually did, wanted to look at pediatric COVID. And we realized that sharing of data was a key issue. Whilst we wanted to look at how the pediatricians in the country think about how the third wave is going to hit, we also wanted to look at an inventory of beds, and we realized that there were some clear challenges in terms of sharing of data from hospitals coming in. And so that's one of the set of challenges. The second was, my experience as a clinician. So in the second wave, I pulled into clinical practice back again. And one positive point that came out in that experience was that human collaboration. So you talked of human collaboration in terms of giving in certain technologies to solve COVID pandemic, but there was a lot of collaboration coming in physicians. So you talked about evidence generation, dynamic evidence generation, Dr. Reddy. And I'll tell you first-hand experience as clinicians. In fact, I was associated with care hospitals. So that's how every week we used to have an entire audit of the patients who were being treated by us, each one of us. And all the learnings were actually shared onto a common platform. And that kind of sort of decided or influenced the way the protocol was going to be. So we actually learned on the go. Now, I'm not saying that's the perfect way to do it, but all I'm saying is that gives you an interesting insight into how formal networks work, but how informal networks work. And probably, when you look at Indian physicians, the way they kind of score is that informal network of knowledge sharing was brought about very strongly within how we actually responded to the pandemic. As a mentor, a business mentor for startups, we had lots of interesting ideas, but I think the basic challenge there was, the eagerness to solve the issue was not matched with the requisite scientific rigor. And I think that's one of the challenges. So I've kind of pointed out the challenges. From a solution standpoint, there are three areas I see where we could look at working for this collaborative program. First is on the healthcare workforce training. I think a big chunk of how healthcare needs to be delivered because the healthcare workforce currently is more focused on the NCD piece. The last 30 years had shifted the entire focus from communicable to NCDs. And the COVID-19 pandemic brought the focus back on communicable diseases. I think that's where a big chunk of the healthcare workforce training needs to be addressed. There are glaring gaps, they need to be addressed. The second piece is around integrating the entire allied healthcare workforce, the workers within clinical care pathways. And what I mean by that is, in a lot of places, you don't have doctors who are actually going to deliver care. And so therefore, you have a host of allied healthcare workers who need to deliver it. But are they aligned? Are they aligned onto a common care pathway platform? The answer is no. So therefore, that's one other area where you would want to look at from a tactical standpoint to how to deliver the best sort of care. And the third piece is we saw, so most of the mild COVID patients were treated by us on telemedicine platforms. And so therefore, there was a clear understanding that healthcare needs to, at some point of time, address the home healthcare piece. And so a part of healthcare has to move from hospitals to home. Now, how do you use technology to deliver that is something that we could also look at. So those are three kind of solutions or kind of suggestions, I would say, where we could dive deeper in one of the subgroups and look at how to address these issues in the future better.
Thanks, Ambuja. I think most valuable suggestions, especially the informal way of evidence generation. I think that was very active. I do understand. In fact, most of the critical care network of care group, I understand what they were doing. But how to institutionalize and how to scale it up across the state, across the country, how to disseminate that evidence in a more informative fashion without confusing with multiple data sets. So this is, I think, becoming an important thematic area of how do we generate evidence live during an active pandemic. I think that is becoming very critical, both from a policy perspective as well as practice guidelines perspective and the overall response perspective. Thanks, Ambuj. I think if N.M. Rao is still present, I would like to invite him because he said he had to drop out for some other emergency. N.M. Rao. I think he must have already dropped out, but we missed his comments. He did mention that from a startup perspective, I think mainly he would like to be a part of how the startups and other entities, especially upcoming future technologies, how they can be roped in terms of the future preparedness. he's not here. So I do see Chang has reconnected. I think there was a drop. Chang, I was inviting you to just brief the work that the teams are going to do in Southeast Asia and East Asia.
So I don't think he's able to connect.
Okay. I think not able to log in. I did see Abhinav in the audience, and he is the driver of this collaborative. So Abhinav, why don't you introduce and make suggestions for this informal gathering?
I don't see Abhinav there too anymore. I think Abhinav has also dropped off.
Right. If you notice anybody that I have to invite for this discussion.
I think we have more or less covered.
Okay.
Yeah.
Yeah, I do have, I think we have our Access Health colleagues, most of them are part of the secretariat team. And maybe I should take this few minutes left for the session, briefly introduce our secretariat team members. Maulik leads the knowledge management portfolio. So he has been spearheading, and one of the key things that he will leverage is as a secretariat, Access Health has been responsible for supporting creation of India Health Systems Collaborative of researchers. What started as just 5 researchers, it has grown to almost 1,600 researchers in health systems across the country. So that is one of the experience. In fact, we thought to leverage how to build these collaboratives. And we can leverage this whole body of 1,600 partners in answering some of the questions which the participants will be raising. A simple question as to how do we generate evidence during a pandemic, and how the researcher will look at from that perspective. Maulik, please do give your perspectives and insights into how the team is going to enable a very productive learning process. Maulik.
Thank you very much, Dr. Reddy. I think so. It also links to the point that Harish made about the dynamic processes, right? And one of the way the learning collaborative that you mentioned in the health systems collaborative that we are kind of currently working on has continuously keeps in touch with all 1,600 health systems researchers with various opportunities. The opportunities to learn, the opportunities to contribute, and opportunities to co-create something. And that continuous process is something that keeps the force together. The second most important thing that we do is also creating an opportunity of this group to interact with policymakers and creating an opportunity for interaction between researchers and policymakers. And I think so those two learnings we try to bring in as part of our global learning collaborative, which can go much beyond. This is very national focus, but what we are focusing on GLC is much international, and we try to bring the same experience out there, both in terms of getting research questions, answering the research questions, and validating the findings of whatever we get out of through this kind of approach. Thank you.
Thanks, Maulik. We have Girish. He is supporting and coordinating in terms of reaching out to the various participants and various members, and also collaborating with other regional colleagues, how to mobilize the participation, especially from the public sector. Of course, there will be challenges in bringing in the public sector, the government machinery into this collaborative. But it's important, at least informally, there is a level of interest. But at the same time, I think this applies across the region, not only in India, but South Asia and Southeast Asia and other countries as well. How do we bring the public sector representatives, the leadership, into a collaborative nature, a dialogue, So we are iteratively understanding how the process works and how the rich learning that comes from the public sector that has to be brought into the collaborative in a mutual way. So Girish, as from Accessel Secretariat point of view, he and his team will be actively pursuing this in engaging and onboarding the various key stakeholders at each country level as well as the regional level. Girish, you can say a few brief words as a part of this closing process of this important introductory informal meeting. Girish, over to you. Girish, I think you have to unmute.
Yes, I think it's clear now.
Yeah.
Yeah, good evening, everyone. As part of this members management, what I would say is that the process is quite simple in terms of onboarding the members who are interested. It's by invitation, that's one. But at the same time is that the terms of reference in terms of participation, normally what we're looking at is the levels of participations from the members who would like to participate at least 3 to 4 workshops in a year, and trying to generate your participation, collaborative and inputs, which would get into different forums of knowledge outputs. It could be a manual to paper series too. We're also putting our learning management system where it could be, peer-to-peer learning, which happens on a real time or if they have missed out. So members participation, and when we look at interregional collaborative networks also, when we participate and discuss, we are trying to put all those process and systems in place, and I'll be keenly engaged with the stakeholders and the members especially. One is obviously at the workshops level, how do we do it? But I think more importantly offline, to understand the requirements which are more important, and gather those inputs which can key in back to the workshops or any sort of communications back to the teams. And we would really like to put in a teams and members for a larger interactions across the Asia Pacific organization. I think the larger thing what we're looking at is that how do we bring in this inter-country collaborative exercise to larger outputs, which would help as we actually transiting through this pandemic. Yeah, thank you everyone. And
yeah, thanks, Girish. Now I request Uma to outline how the team is looking at a dissemination of some of this learning material to all the participants and the partners and the members, because that is one of the, I think, important component of this learning process. So how the team is proposing to do that across the region and ultimately across the globe. Uma, over to you.
Thank you, Dr. Reddy, and thank you everybody present here this afternoon. I'd like to start by saying that communications have come to the forefront globally like they'd never before. And if you see how we have changed the way we communicate, there are multiple levels of whether it's face-to-face communication that's now become virtual, like we are all sitting in a virtual room today. And how digitization has played a significant role in, whether it is telehealth, medicine, communication handles, and the virtual print to television media has now been taken over by so many other mediums of communication. Yet, if you look at it, what has the pandemic done to us? It has brought us closer. Family time has gone up. During the lockdowns, like Vijay said, we didn't know whether it was good or bad, but it did bring a lot of families together and definitely brought many people under the same roof to understand what their pains and gains were both. The governance communicated continuously with us and to its publics, and globally, if we saw each of the prime ministers or the presidents of those countries brought to us something that came right down to the grassroots, to every single person to understand whether he needed to actually even sound his bell or light up a light on a specific day. Having said that, when we say communicate to collaborate, that's what we do. A collaboration cannot work in isolation, and we need to collaborate right down to the common man, as has been expressed, So our dissemination is going to work towards collaborating and providing that message as we go down, which is authentic, which is powerful in its communication and experience, which has new ideas, which will lead to new ideas and innovations for many to take forward, and provide a multi-stakeholder engagement across all strategic goals that have already been communicated this afternoon. The framework that we are going to use is to design and take across something which is easy for stakeholders across different regions to be able to communicate and collaborate. The print and electronic media, plain vanilla, but very, very effective and takes us across regions, is something that we will work with. The web platform is almost ready, and you will see it up soon, where all of us will actually be able to provide information and also use our knowledge management and learning management systems. Both have been outlined by Dr. Reddy and Maulik, they are going to populate with research, with already existing evidence, and how members want to see it. It will take shape as we would go forward. The social media handles will continue to buzz, because that is now the new bit, and it's going to stay. We're going to make sure that we keep communicating all the thoughts. Some of the pearls of wisdoms that we even gathered today will continue to be part of the media handles for people to understand and take away from this collaborative. Events and meetings of this kind, please be kind to us and please make that time, which you already did today. And we are grateful for that time that you have spent with us, because it will guide us into the next level and realm of learning, and also understanding how we can hopefully do away with all this and make sure that we have a new normal that we have been talking about for the last 24 months. Looping in and feedback is something that we will not miss out. So we will continue to communicate, loop in, track, come back, and see how those outcomes perform. And of course, what I will also urge as we go forward is how do we collaborate to find those donors who will make sure that these relationships that we are strengthening, and our partners and our members and our invited audience will continue to be a very, very important part of what we are going to take forward. So thank you, Dr. Reddy.
Thanks, Soma. I think good overview on the communication, which is critical. I think one is I should thank everyone who patiently.
Sir, may I wrap up? I have notes. Whenever you're ready, I would like to wrap.
No, I was just thanking from my side. I don't know what you want to wrap it up. Yeah, I think over to you to wrap up the session on behalf of Accessel. I just only wanted to say that, as I mentioned in the beginning, this is just a beginning, like a rivulet, and multiple rivulets will join from different states, different countries, different regions. And so we will follow through this meeting. One, of course, is valuable suggestions that we received from various members, from various stakeholders. Some of them are already inbuilt into the thematic architecture, but some of them are new, so which will be incorporated into those thematic areas. And some formalization process, and also communication in terms of the actual learning sessions when they begin. I must also announce that the first thematic area that the group has taken up is with reference to the overarching, the health systems assessment framework. I mean, what are they really working? Are they covering entire gamut of the pandemic preparedness? What are the gaps in the existing frameworks? And what are the expert opinions in terms of and how to make these frameworks actually practical and impactful. Are the people actually using these monitoring systems? We may not call them frameworks, but unless the leadership and governance uses some monitoring system to know where the health systems are. So this is the first thematic area that the research team had already collated the secondary research work. It is going through internal iteration, and once it is taken through our regional colleagues as well, then it will be taken through the experts and then some of the practitioners who actually monitor the health systems. And then that will be one of the first thematic area of learning session. I think shortly that will be communicated when that peer-to-peer learning process will be there. The meeting dates and other things are finalized, of course, subject to the Omicron, how it is going to shape up in different regions. So this is my closing remarks in terms of what are the next steps as a follow-up to this initial meeting that we have. As usual, Access Health was born in Hyderabad. Joint Learning Network was born in Hyderabad. And maybe this is the birth pangs of Global Learning Network, but it should reach to the global proportions. Thanks, Uma, for helping in organizing this meeting and your team. I think it was a wonderful discussion. At least I enjoyed the discussion. I don't know about all the other audience in the thing. Thanks, everyone. I think over to you, Uma, for your closing remarks.
Sir, I couldn't do this the way you would want to wrap it up. But at the same time, the reason why I said I would want to wrap it up is because some of those key takeaways are something that I just collated as we were going through. And I was just going to share it as one of those things that we will keep as some of our cornerstones as we go forward. We heard about autonomy, we heard about equity, we heard about One Health, we heard about advocacy and the citizen's voice. We heard about institutions of animal health and agriculture for the longer bit. We also heard about how authentic knowledge can actually be used in simple knowledge and language, which will become then an easy way for transformation and translation. We also talked about autonomy of dignity, and we talked about some intangibles that needed to come across for the global world and the inequities of the global world that were actually going to be a part of it. We also talked about evidence-based medicine, because while research is always going to be there, it's going to lead to something. And those that are using that should also find and remember that this was a strong thing that we actually used to have. Then aligning and designing from a care platform was something that we looked at. Capacity building became something that's important, and especially leadership that will come across as we go along. Threat perception and mitigation was also something we looked at. And the effort to bring in partnerships with other alliances was yet raised with DST, CST, CSIR, DBT, and all the other scientific bodies.
Uma, just an interruption, sorry. We have Vinay from CCMB. In fact, he dropped out in the middle. So he rejoined.
So it will be a privilege.
Yeah, just now you mentioned CSR, so he is the spokesperson for CSR.
Yeah.
Vinay, please.
Sorry, I had to go for a meeting.
Yeah. I will catch up with you in person to brief on this.
Sure, that'll be good. Thank you.
Yeah, just, I mean, you can suggest for this effort how some of the public R&D institutions can be part of this collaborative.
I mean, maybe once we talk in person, I can do that next time around we meet.
Okay.
Let me get a...
Thanks, Vinay.
Thank you.
So Vinay is the director of CCMB, so just for the rest of the audience. So we just were coming to a closure of this meeting. Uma, you have any words to, sorry for interruption, but I thought it's important to introduce Vinay.
Thank you.
So I did encourage him to stay on, but he couldn't, I guess. So thank you for coming back. And definitely that one-on-one is not something that you will go away without this extra 1 hour that you have to be a part of.
I'll come back. I'll come back.
I guarantee you on that. When you sit with Dr. Reddy, time flies. And we will look forward to all that.
For multiple reasons.
All those, yes, for multiple reasons. And we look forward to all that we have missed on this session.
Sure.
We are going to take forward this into multiple iterations, as already been suggested by all the participants. Collaboration is the cornerstone that we are going to look at as we go forward. Relationships is what we will rely upon as we also come into the next realm of the birth pangs that Dr. Reddy talked about. And we're going to see how much we can strengthen these relationships to collaborate. So it is about all these relationships that will come forward together to ensure that we have a collaborative effort into the next couple of years that will become a very, very strong binding force for the academia, for the advocacy, for the research and scientific community, and of course, the people that deserve it most, the publics at large. So thank you, Dr. Reddy. It's a great opportunity.
Thanks, Uma. I think thanks everyone. Thanks everyone for joining, and we'll be in touch soon. Thanks everyone.
Thank you.
Thank you, Dr. Reddy.
Thank you.
Thank you, Dr. Reddy.
Thank you, everybody. Thank you. Thank you, Dr. Reddy.
Thank you.
Thanks.
Bye. Bye.